Um, and thank you guys for joining. I'm Sara McLaughlin. I'm one of the physical therapists for Camp No Limits. And I started in with camp because I actually attended as a parent, as a family member. My son is a congenital below the knee amputee. And we went with my daughter, my son, and my husband when my son was 6 and my daughter was 9. And that was, I think, 2011. I was a PT before I had my son. So camp kind of fit right in with our journey as a family. So then, and I've been a PT, I guess, a little over 20 years, but a lot outpatient, and then working with camp. So first, just a little bit of an overview of what we're going to be going over. Camp No Limits mission, just to give you an overview of what camp is about. It is different than sort of in the clinic. So just to, both of you are new to camp, to learn a little bit more about it. Some of the common congenital lower extremity differences that we see at camp, the levels of amputation, the team approach, and almost sort of the family perspective and how important the team approach is for the families, and then considerations for setting and achieving the goals. Camp No Limits, our mission is to educate and empower young people with limb loss and limb differences and their families to discover and develop healthy, happy, independent lifestyle. And we do this with the help of amazing volunteers, mentors. So we have clinicians, we have adults with limb loss and limb difference, and just general volunteers too that may not be clinicians that are there, but all to help fulfill our mission. This is just a quick video here to give you an idea of camp.
Camp No Limits has started out as a really small camp with very few people, and now it's stretched out all over the country.
So with that, we've developed our mission. Our mission is to educate and empower young people and their families with limb loss to develop and discover a healthy, happy, and independent lifestyle.
To help them just see what's out there, learn about different prosthetics that they may be able to use to bike, to run, to kayak, or any sport that they want to try.
What makes Camp No Limits very significant is you have a collaboration.
So at camp we have a variety of healthcare professionals. We have occupational therapists and physical therapists and prosthetists who staff our camps, psychologists and social workers to help educate, empower, and support our families.
As we come together for Camp No Limits and have an incredible educational experience in that concept that there are no limits in the life that you live.
All right. Oh, look, it did go through that. Hold on. And then, so that gives you a little bit about camp. And, as we go through this, I'm going to veer off a little bit from what I have, just because, so on here right now, we do have also Adrian, who was one of the original campers, and is now an adult mentor at camp, and Bella, who has been a camper at camp and is now a nursing student in college. I'll be, guys, I'm gonna call you out on, put you on the spot on some of this. I mean, Adrian, I already told you, Bella, I hadn't told you. But so as we get into some of it, and then because there will be, after I present, there will also be another parent of 2 of our campers will be on, and I'll be talking about those campers here. But I will be weaving you guys in, Bella and Adrian, just to to warn you. So with congenital limb differences, there are, let's see, about 1,900 births involve a limb difference each year, which is about 2,000 babies born. Some are born with upper extremity differences, some lower, and some have both. And then from there, the common congenital differences that we see at camp, some of these, there's longitudinal differences, which is the partial or full reduction of the long bones, the tibia, the fibula, the femur. And we see these three types very often at camp. But one thing that I wanted to sort of point out for therapists is that just because someone's going to have the same diagnosis, they may have a very different presentation, and they may have some may have surgery and amputation, some may have limb lengthening. They're all addressed in different ways. And this is where it's so important, just, the team approach and family approach, just really getting to know the families, talk to them, see sort of what their journey has been, because everyone gets to a place sort of a different way. With the congenital femoral deficiency, that can vary significantly in severity, where you may have someone whose limb is just a little bit shorter and maybe has a slight, defect in their hip, or you may have almost no hip joint and a foot that is not functional. So it really can vary, and then sort of the treatment of that and how to make that person, a functional ambulator is gonna be different. And also the same for fibular and tibial deficiencies. You're gonna have, sometimes there's associated joint instabilities with those. So you just always wanna be aware of making sure you're either talking with their doctor or talking with parents, like what are, what other, is there anything else that goes along with their diagnosis and their limb difference. Limb lengthening is a consideration for some. It's a whole nother whole nother thing compared to the amputation surgery. They have to decide if for some people, it's only right if the integrity of the ankle and the foot and the knee are there, but it also is multiple surgeries. It's a lot of time away that a child, can't be out playing with their friends. It's about 1 month with the fixator on for every centimeter of growth that they're looking for. So there's just a lot that goes with it, and really having to follow through with PT and everything. So that's not always a choice for each family, but just knowing that there's different sort of options and different decisions that families have to make as they go through this. So those were longitudinal deficiencies that we just talked about before, and then transverse deficiencies where the limb just doesn't really form distal to the level of involvement. And that includes amniotic banding. This is my son. We found out at about 19 weeks pregnant that his right leg didn't fully develop. At the time, they didn't know exactly why. They could see that he had a knee, but they weren't sure if the knee was functional. And then when he was born, they decided it was amniotic banding. And as you can see here, there's just this tiny little bit of tissue at the end. And he did have surgery a few days after he was born. I actually don't really remember. Maybe it was a week or so after he was born. But he had surgery early on. And as you can see, this, he's about 6 months old there, and it just sort of ends. He's ready for a prosthetic. But that is not the case for everyone. It can vary. Even with amniotic banding, there can be scarring in different areas. There can be, they think it's from fibers that rupture in the amniotic sac, and the fetus gets caught up. And so, it can get caught up in fingers and cut off circulation, and in different areas of the body too. So congenital amputations are most common, and then trauma is about twice as, you'll see as many from trauma, twice as many as you would from disease. And then does anyone know, you can put it in the chat, about how many amputations occur each year, pediatric amputations occur each year due to lawnmower accidents? Anyone? I can't actually see the chat, so Mary's gonna have to let us know in the chat there.
Bella said 200. Anyone else?
Anyone else?
Someone?
It's okay to be we
100.
go over under 200.
We've got 200 and 100.
All right, it's actually about 600, and this includes, it could be a finger, a toe, it's some type of amputation that occurs, but 600 injuries and amputations from lawnmower accidents each year, which is surprising. All right, and then so levels of amputation, if they're going through the joint, it's a disarticulation, so a hip disarticulation or knee disarticulation, and then through the tibia, transtibial or below the knee, and through the femur, transfemoral or above the knee. At the foot there, I mean, there's different ones with transmetatarsal. In older adults with diabetes and poor circulation, you're going to see more where they kind of go through some of the taken off toes and transmetatarsal and kind of going up. What we commonly see at camp is different types. You'll see a Boyd's or Symes, which is just the type of surgery they have. And that is sort of keeping the, some of them are keeping the heel, the calcaneus or the heel pad, so it is a weight bearing end. And one thing just to note again, so, you know, you may see written as a diagnosis that there was fibular hemimelia, and you may see one child that has a very long residual limb, and then you may see another that was a knee disarticulation, and it really depends on sort of, you know, it can vary what the differences are, even with sort of the same congenital diagnosis there. And the thing to remember with any of this is that the longer the lever arm, the sort of the, in a way, the easier it is to manage a prosthetic, just in the fact that if you have a very, very short residual limb, especially for above the knee or transfemoral, it's harder and a lot more work to control the prosthetic because you're controlling the knee and then all the way down. And that being said, if you have a very long limb, sometimes you would limit what choices you have for prosthetics. Adrian might be able to speak to that some as we go on. All right, some complications, just as kids are growing, I guess something to, as a physical therapist, to think about when you're seeing these kids in these families is it's, you know, it's not always just, oh, they've had their one surgery and now they're done. There are complications they can have. They may require other surgeries. The bony overgrowth is essentially like a bone spur, like a spike that occurs on the end of the limb. And that, you know, can, you know, we know kids at camp that have had several surgeries for that. My son has had, I think, 4, and that's not, you know, that's far from the most that I've heard with some kids. And then skin integrity, especially when it's been trauma or disease, when you have skin grafts involved, that's stuff that you have to really watch out for. There's a lot of shearing inside the socket, and well, there shouldn't be, but there can be. And you know, it's a sweaty environment, so it's sort of set up for some skin issues, and the skin can be fragile with skin grafts. So you really want to make sure that that's something that you're aware of. And then growth plate involvement, whether it's trauma or disease, it can damage one growth plate and you can get some uneven growth and get a lot of varus or valgus. And so it's just things that you need to kind of be aware of. And again, also where members of the healthcare team, it's important because everyone should be kind of looking out for it and helping the family navigate some of these complications. This is just, again, my son who may be on later if he is home. But this was, so he had 3 revisions within, between the ages of like 3.5 and 6. And this was at age 12. He was very reluctant to have surgery. Understandable, but at the same time, this is what his limb looked like. The prosthetists were doing their best to accommodate his limb in prosthetics, and they were trying to make a custom cap here, but you can see that the soft tissue just didn't come down. And that obviously is very hard to not have all the weight right there. So as they were not able to really accommodate that, his function declined, and he finally decided that it was time for surgery. So then this was what it looked like after. And you can see the importance of wrapping because it is a little swollen, kind of bulbous on the end. That was, I believe, the first after he had like 2 weeks where he was in a splint, and it was after that. And then, you know, looking better by the time he's almost getting fit for a socket there. But just always remembering it's, you know, as you're working with kids, working with the families, you know, it's all a process. Like even as we were dealing with this, you know, we went in several times for the appointments with the prosthetist, and then you're at the doctor's, and then you have all the post-op stuff, and it's it can be a lot. And you know, just keeping in mind people have other kids, people have jobs, and it's a lot as people are trying to navigate this, and every family's kind of in a different place as they're navigating all of this. So I'm going to see, does anyone know how old a child can be when they are fit with a prosthesis? Adrian, you're not allowed to answer until the end. You can tell when you got your first one. You got anyone in the chat there, Mary?
4 months.
Close a little bit later, typically.
When they pull to stay for lower extremities, 6 months for upper, 6 months, 6 months.
Yeah, so that when they pull to stand for lower is right there. Adrian, when did you first get yours?
I didn't have my amputation until just about the 1 year mark, but I was fit as soon as I healed from the surgery. So I learned to walk with it.
Got it. And so yours, do you know about your parents' decision with the amputation and why it was about a year?
Yeah, so I was born with tibial hemimelia. And so ultimately my parents decided for like a Symes amputation, which is like through the ankle joint. The advice given to them was, even with lengthy surgeries and limb lengthening options, I probably wouldn't have been able to walk with the anatomy I was working with. I probably would have gotten the amputation sooner, but I also have a congenital heart condition and had surgeries for that. So priority of medical conditions, my amputation was put off until about a year old, but that's probably later than it like would have been.
Yeah, thank you. Yeah, so a lot of children that either are very young have a trauma or disease that causes amputation, or they're born with a limb difference. They can hit milestones at the same time as their peers, you know, crawling in that 6 to 9 months, pull to stand. If there's a bilateral lower extremity difference, they may just pull to their knees. But kids just try to, you know, keep up with other kids or try to get at what they want. You know, they're developing normally often and just working with what they've got. And it will, you know, it will vary when you start to get into walking. That varies depending if they are an above the knee difference or below the knee, and also if it's bilateral. You may, children may need a walker to start, more commonly if it's bilateral, or possibly above the knee. And it used to be that more often for above the knee differences, kids would get an articulating knee between 3 and 5 years old. but they're starting to be a little bit earlier now, some even at 18 months, again, depending, all situations are different, but if the child is ready for it, they learn a better gait pattern then, because if they're using, if they don't have a knee, an articulating knee there, they start to circumduct or hike their hip, and they, you know, learn some incorrect patterns. So they're starting a little bit younger. And again, someone with a bilateral difference, it is different. But kids sometimes will have manually locking ones, so they can lock one side and unlock the other and start to learn to walk on it that way. And that is typically a little bit later than the if someone is unilateral. This is just a little fun video for showing some normal, you know, meeting milestones. This was his first prosthesis, you know, just trying to climb, pull to stand. He was about 8 months old. And even without the prosthesis, there you go, pulling up, just trying to keep up the sibling, but also going quadruped to sitting, you know, in sitting to quadruped, all kind of typical development there. There we go. And that's just walking. He walked at about 15 months old. It's before the day of the really good cell phone videos and everything. So it's poor quality. All right. So here I saw Jennifer, Anna and Ivy's mom, come on before. And so she's part of our panel too. So for questions afterwards. But so it's Anna and Ivy. And Anna here was diagnosed with congenital femoral deficiency. And at 2 years old, her right leg was about 6 inches shorter than her left leg. So she initially had a foot-on-foot prosthesis, which I do have a photo of later on. And then at 4 years old, it was decided that a rotation plasty would be the best outcome for her. And that isn't always the most common for the congenital femoral deficiency, but her hip was essentially a non-functioning hip joint. So she was on the severe end of the CFD. And then, so what they did with the rotation plasty is they take the tibia, they rotate it around. It's attached to sort of so actually, Jennifer, if you're on here, is Anna's hip does her knee act like her hip?
Yes. Yeah,
okay,
it does.
That's what
so she didn't ever have a fully formed hip, like a ball and socket. You can't even see that on an x-ray. And so what they did during the rotation plasty surgery was they fused her little femur that she did have to her pelvis, and everything was turned. So now her hip her knee, what used to be her knee, is now her functional hip, and it's much higher, close to where an actual hip might be, a little lower, but then her ankle is her functional knee.
All right,
Yeah.
Thank you, because the hip part.
We need a picture, Sarah. I should send you a picture of like what it looks like without the prosthesis, because it's so hard to explain.
Yeah, I'll add that in for the next time.
Yeah.
Yes, and so with that, with the hip, you obviously then, as the knee, you only have flexion and extension. You don't get some of the rotation and abduction and adduction, but as it is used and developed, from a young age that way, she learns to compensate and just get as much motion as she can. And it did have PT after surgery, and then also after getting fit for the prosthesis. And then now I know she's quite active, which is fantastic. And here you can see she has a hybrid foot. which I'm sure it took a little while before she could actually fit one underneath there till the other size, till she grew tall enough to have choices to put under there. But that, what sports does she do now? Does she playing sled hockey?
Yeah,
Or
well, so she's done really well with rock climbing, and she has climbed with the prosthesis on, but within the past year, she's discovered that she really likes climbing without. And so she'll actually put a rock climbing shoe on her little foot that faces backwards, but then she's able to manipulate that foot and get it into a hold and just use it more, because otherwise it's kind of just hard to like swing that big heavy prosthesis up and into something. So she does that, and both girls have really gotten into wheelchair basketball this year. So that is their newest thing, but they've done a lot of different things. Yeah, they even tried wake surfing this past summer. That was a new one.
Nice. I love it. And actually, how old are they now?
Anna's 10 and Ivy's 9.
All right, and now we're gonna move on to Ivy. So Ivy diagnosed with bilateral tibial hemimelia, and at 2 years old had bilateral knee disarticulation. It was casted for about 2.5 weeks, and at 5 weeks post-op, she was fit for her first stubbies, which stubbies are really just sort of like a socket with kind of looks like what's over here. A socket, and then just has some kind of little thing on the bottom, and some may have a little bit of a pylon, but it's usually a pretty low to the ground, and it's often used because the people learn balance and develop the strength that they need as they kind of are able to then lengthen the legs eventually. And Ivy was able to pretty much walk right away. I think I remember you saying she didn't really need PT after, just in the stubbies taken off right away. So again, just a difference in different surgeries and different kids and everything. Just as a PT, you will see it at different stages, and it's always just kind of meeting people where they're at and what their needs are. So then Ivy had her first articulating knees at 3 years old, was a little bit disproportionately tall and found it challenging, and used a walker to help with that. But then it became easier as she grew. And then running blades at 5, which she loved getting around in, as many kids do. And she didn't have articulating knees with her blades, did she?
No, she actually, it's a manual knee joint though, so that when she sits on the toilet or in the car, she can, fold the knees down. But otherwise she can fit, because it became really hard to get her in the car with her legs straight out. So this way, she can manually pull something and it flexes down, but otherwise they're locked in place whenever she's moving.
Yeah. And there are a lot of kids who are have the bilateral above the knee difference who love having the running blades because they're faster, it's light, they're pretty agile. The only thing is they can't really stand still because there's no heel. So it is hard to stay still. And so I don't know, is this information still correct, Jen, that she still uses a wheelchair sometimes for long distances at school?
Yeah. Yes. She does.
Yeah. Participates in a typical PE class.
She does.
And then awesome. And then uses a stroller for long distances or ice and snow, because you are up in the Midwest in the
yes.
snow country.
Yeah, she doesn't really have any, even on the blades or no real traction to get around.
Yeah. And it is hard to navigate. So thank you. So that is a little bit of Anna and Ivy's journeys with their limb differences and surgeries. And so next I want to talk a little bit about when you're working whichever discipline you're in, working with the children and the families. It's really important to consider the team approach, education, and motivation. And the team approach, this is not an exhaustive list, but it, you know, any of these people may be part of the child's team. And it's really important to communicate with the child and the family, find out what their needs are, their goals, what are there any barriers to meeting these goals, or their cultural influences, and really as a whole team, you know, like looking at the confidence of the child, the social emotional health, is there anything that can be done to collaborate to help lift these? And again, every family is different. You may have a child that, you know, doesn't have a social worker or a counselor, or, you know, and helping them to find one if they need one, or, you know, getting them in touch with, you know, an adaptive sports, if that's something that they're interested in, you know, knowing what resources are around you. And then definitely as therapists, you know, connecting with the prosthetists, with the physicians. You know, we see there's so many different, you know, things that can be involved musculoskeletally with any kind of congenital difference, or, you know, or with trauma or disease, you know, making sure that you have a good understanding of all of that. And with the prosthetists, you know, you want to know how the prosthetic works. So you know, should be in good contact with the prosthetist, making sure that, you know, you're educating yourself so that you can help the child get, you know, the most benefit from their prosthesis. So education is a big part it's a part of camp. It's an important part that working with the families and the campers, or the, you know, if it's your patients, if you're in the clinic, and getting the children involved is huge. Like, they should be an active participant in the education. At camp, we have what we call show and tell, where, you know, mentors will talk about how to take care of their limb with hygiene and everything, but they also talk about their prosthetic and sort of how it stays on, and their suspension and different things. And while parents like to just see what's out there because something different works for everyone, it's good for the kids too, because it helps them learn to talk about their own leg and learn about their leg. And, you know, they should be comfortable with that. They should be confident in it, and they should own it. It's, you know, it's part of them, and can help them answer questions when, you know, they're out in public and people are asking. So it just helps them get more comfortable with that. But also in the education, to make sure that as a therapist, have a good understanding and are comfortable with all of these three things, but also making sure that the camper or the, you know, patient and family also understand the importance of like a socket, fit, and suspension. If you don't have if that's not working, the socket, fit, and suspension, you're not going to have good function. You know, you'll have no stability if someone's in pain because the socket doesn't fit. They're not going to be walking well at all. And in order to understand that, you should have good communication with the prosthetist. So it goes back to the team approach. And then, the importance of proper gait and posture. These are things that, there's a lot of overuse, on the sound side, if someone's unilateral lower extremity differences or limb loss, a lot of hopping, and that can lead to hip pain, back pain, a lot of differences that way. And so it's important for, parents to notice, like, okay, when your child's, playing with their Legos, are they standing somewhere and just, like sinking into one hip? Are they, what kind of position are they in? Are they always uneven? Just looking at things like that, but also they should start to notice, like, oh, if they're walking and suddenly you're like, wait, you don't typically walk like that. Like, is it time to go to the prosthetist to see, have they grown? Does it need to get adjusted? That kind of thing. Just making sure that families are aware of that and sort of reinforcing everything that, that has come from the prosthetist as well. Because sometimes, you know, it can be a long day when you're at the prosthetist office, depending on how long you're there and getting fit and all this stuff. And so maybe they're getting this education there, but by the time they leave, you know, how much of it is really sinking in? And so you want to be another person that's reinforcing, you know, all these things about the fit and making sure, you know, do they need an extra sock for volume? And, you know, if they have a lock and pin, is it clicking in all the way? And do they know how to make sure that it is? And all of that information. And proper hygiene and limb care, that's you know, critical, and kids should be involved in that early on. I was guilty of not getting my son involved early enough. But you know, kids, you know, should know that they need to check their skin, they need to clean their liners, clean out their socket, because a bit of prevention can really help being out of your socket because of a sore or because of, you know, some skin issue where you could be out for 2 weeks, you know. So it's really important, you know, as a therapist to go over all of that. And at camp, we make sure that we cover that as well. And then motivation, as you're setting goals, it's really important that you're kind of including that you're talking to the child and the family, but seeing what's going to motivate them, you know. And at camp, sure, it's different. We're, you know, trying to have fun while we do our PT exercises and everything, and our goals there are very different. We want to have a safe space where they can try different activities, or, you know, work on something that maybe that, you know, they're not comfortable doing when they're at home or in PE class or something like that. But, you know, in general, you want to make sure that, you know, what does the child want to do? What does the family want to do? You know, it's important to really listen to them, because if you're, you know, making sure all your goals align, because if they're not really aligned, or you're not really looking at the whole picture of what the family's dealing with, then, you know, you'll get frustrated feeling like, well, they should be able to meet these goals. But when you look at the big picture, you know, there's just a lot more going on. You know, maybe you think, well, why, if say a child is trying to learn to use their articulating knees, and you think, just wear them to school. Well, a child who previously could run around the playground because they were on their running blades or stubbies, and now is much slower and can't really play on the playground as well because they're, you know, in these articulating knees, and they're a little bit afraid because they're higher up and they're afraid of falling. You know, they're not going to want to wear them all day at school. And so it's really kind of working to meet what the goals are and what's going to motivate the child. So basically trying to everyone navigates it differently, meet people where they're at, try to give them tools so that they can meet their goals. It's fine. So this is one other camper I was going to go over, and she has but one thing I will point out, because we'll talk with our panel after this. But I do want to put out, this is the foot-on-foot prosthesis. So this camper did have, her foot wasn't fully functional, and at one point she did have surgery to reconstruct the foot, but it was still never fully functional, and so it was a foot-on-foot prosthesis. But then when she was 13, they decided, which was just in 2020, she decided to have it amputated and become bilateral below the knee. And for various reasons, not being able to wear some, you know, clothes that she wanted to wear, being concerned that she's going to have a lot of foot pain and differences and issues with the foot that wasn't fully functional. So a lot of reasons that they decided to amputate, you know, sort of later on. But let me stop sharing here. So that hopefully gives you just an overall idea of kind of how many factors there are when you're working with kids with limb differences and their families, just how many things factor in, and it's just not always straightforward. You may be seeing them for this little period of time, but there's always a history of what the family's gone through to get to where they are when they're seeing you. So let's see if we can have Bella and Jennifer there. And then if anyone has any questions, so I guess well, Jennifer, we already introduced you as Ivy and Anna's mom in there, but Adrian, you spoke a little too, but if you want to introduce yourself, and then Bella, you can introduce yourself, and then if anyone has any questions for any of us.
Sure. Hi, everybody. My name is Adrian. Like I said earlier, was born with tibial hemimelia and foot amputated at about a year old, and I've used prosthetic legs ever since. I started going to Camp No Limits when I was like 8 years old, I think. I'm now 26. I, for a long time, went to camp as a camper with my family. Now I'm one of the amputee mentors. I never went to physical therapy as a kid, so my first exposure was at camp. I always did dance classes growing up. That like ballet exercises was kind of my like fake physical therapy. And yeah, now I've never been much of a sports person, so I mostly stay active by doing like camp kind of exercises when we're there, doing yoga, dancing, things like that. Yeah.
And then Bella, if you want to introduce yourself.
Yes. Hi, my name is Bella. I am a quadruple amputee, so I had my amputations from sepsis, so it was more trauma than like congenital or anything like that. I was 8 years old, so yeah. And then I think I got into camp like when I was 14. So it was a while before I got into camp, and I didn't know a lot about prosthetics. I had them, but for a really long time, I only used prosthetic legs like during PT and stuff like that. I had PT once a week. And then I had like therapy basically once a day in school too. So that was kind of when I would work on my legs. And yeah, I've been kind of getting more into my legs recently, trying to use them more and not just use them for like physical therapy, but also like getting to use them more independently and frequently. But I'm still in stubbies. So I have my stubbies, and so they're the little ones that go to the ground. I have used knees before, but I don't really remember a lot about those.
Yeah.
But yeah,
That's great. I'm excited to see you using your stubbies.
Yeah, I had them at Florida camp a bit, if only. Next
He was
camp.
really moving around at Florida camp. It was really cool.
I
Yeah.
had them a lot.
And I think that goes a little bit to the kind of meet people where they're at and I know because Bella, you do have a short residual limb.
Yes.
So it is difficult to manage the full prosthetic. And I know, and there's skin, from skin grafts and different things. So it's a process.
It is a process. And also because I'm missing my arms too, it's like another challenge of getting it on myself. So that was kind of another setback, but yeah, that's kind of where I am with the prosthetic legs.
Yes, and in nursing school. So that's fantastic.
Yes.
Yeah. Yeah, and then Jennifer, you can introduce. I don't know if there's any more you want to say.
Yeah, I'm Jennifer Cosgrove. Anna and Ivy are my daughters, and we adopted them both from China. You could probably tell. They were just under 2, both of them. They're a year apart, but they were both each just under 2 years old when we got them. So Ivy's surgery was pretty soon after she came home. She's a double amputee. Anna's was a little later, like was mentioned before, with the foot on foot brace for a while, and then the rotation plasty. And yeah, they've done really well. The rotation plasty was a big decision for us to make because it is something that's rather unique, and it looks really odd if you see it without a prosthesis because the foot is hanging about halfway down and facing backwards. But so far, we've been really pleased with how Anna's been able to get around and her mobility. And as our surgeon said to us when we were making the decision, he's like, this way you preserve her two best joints, which we're like, oh yeah, I mean, in a way that she's able to keep those rather than alternatives, which were fusing that knee or the ankle or both. So yeah, she might need, we learned recently at a recent visit back out to see her surgeon that she might need a little bit of a corrective surgery. That happens, he said, in about 30% of his patients where with the rotation, there's some derotation. So the leg wants to turn back, and it's a pretty simple osteotomy. Like they break the bone and then he sets it how he wants it. And then she's basically in kind of a splint type of cast for 6 weeks or so. And hopefully that's it. So we'll see. That's in our future for sure. We're not exactly sure when. So we're in the midst of, yeah, she's got a prosthesis that's fairly new in January, but figuring out what is just her issue some days and getting it on, and what is possibly a more significant medical issue with the way the foot is turning. That's always a problem, especially with children with sensory issues, which she has, like distinguishing between what is, legit and what is just kind of, well, it's all legitimate, but you know what I mean? I mean, it's just tricky.
No, it's tricky. It's distinguishing. I remember when Sean was much younger, it's distinguishing what of this is him being this age and what is you have, like, we need to go see the prosthetist, like what?
Yes.
Because it can be challenging.
Yeah.
Yeah, and sometimes it's about how you ask the questions and how you start, like, because my son did not like to walk a lot. And there was a period of time where he had a lot of issues with the prosthesis. So we were like, we had to come down to like, are you tired? Is it painful? Or do you just feel like not walking? And we had to be okay with that decision, that choice of like, you just want to stop walking, because it became this like, I don't know if there's a problem or not.
Yeah, well, you have to,
he was just stubborn.
Yeah, you have to figure out what they're feeling, because like they're children. So
Yeah.
you have to like and guide them into knowing, and so they know what they're feeling. And so yeah, I can see that being tough, but
yes, it was definitely, yeah, it was a journey. And I think even like Sean went to PT sometimes, and it was even in PT, they're only there for a little while, and it's trying to get them to do the thing, like talk to the person, and I don't know, see, they're all, I felt like when he was younger, he would just walk funny because that's what he was doing, not because he was being silly and goofy. Let me see. Thank you for sharing tonight. Oh, how did everyone find out about the camp or start getting involved in more community activities? It's funny. So let's see, we were about 2011. Camp didn't have a huge online presence then. And you know what? My son's prosthetist happened to be volunteering that summer, and someone else had talked about it. And to be honest, we were like, we're gonna go. We drove. It was because it was local one. We were like 3 hours away. But we kind of took a chance and didn't know what we were gonna do.
Sarah, was that when Sean was still at Next Step or no?
Yeah.
Oh,
he was at Next Step still. Yeah. So yeah, because he was 6 and Jordan was 9. And then yeah. And then Adrian, you were local to Mary when she first started camp, right?
Yeah, I went the very first year that camp started, so there was really no marketing and it was very different. But I found out from my prosthetist who found out from Mary. And for other, like throughout childhood, for like other like adaptive sports and other things like that, a lot of it I found out from camp. There's kind of like the cliche joke of like, just because I'm an amputee doesn't mean I like know other amputees, but I kind of like do, because you get once you get connected to like one resource, often it's easy to start sharing those. So a lot of other like adaptive sports organizations, or even like prosthetic related services and products and things like that, most of it I found out from camp. Although there are some there's a variety of different like online communities too that people have used, including like I know my parents have used it. So that's like another way that I've been connected to things.
Yeah. And then Jennifer, how did you guys find out about like that wakeboarding that the kids did,
Yeah.
and the wheelchair basketball?
I feel like it's yeah, the more you get connected or plugged into things, the more that network grows. And so even tonight, we were at a wheelchair basketball practice right before this, and there was I just like, I guess I try to just talk to people at all of those things and just get them talking. And then it's like, oh, I didn't know that this university that's 40 minutes from my house offers a summer wheelchair basketball camp. That's awesome. Or there's like a Wisconsin
amazing.
Adaptive Sports Association offers tennis, and it's like in our backyard in the summer. I just learned those two things tonight, and it's because I'm standing around with these other parents, like starting conversations. So you get talking and you just like, and the network just grows. We found out about rock climbing through, I can't even remember, through somebody else. And then we start going to these things and meet somebody who knows about the wakeboarding or adaptive skiing. We did that this winter. And so I would say just like word of mouth, and we've even had like, this is even as therapists, physical therapists, we got to know our physical therapist really well back in the, we don't go so much anymore, but we're friends on Facebook. And so she'll reach out to me sometimes and say, hey, I've got a family who's kind of beginning this journey. Will you get in touch with them? And I love to do that, because it's like, I'm learning all these cool things. And the older my girls get, the more I know. And so, yeah, knowing like who as therapists, like, if patients are okay with that or families are okay with that, making those connections or helping with that has been really helpful to us, and I think other people too.
Yeah, I think that's a huge way. And I do think even like, I know around here, so my son doesn't do any adaptive sports, but he, like growing up, he did try like sled hockey, and now I think there's like 2 or 3 other sled hockey teams that are like not that far away. Each, you have to drive a little bit, but it is, I think, all that, just different adaptive sports things have grown. And we used to go to these, different activities. There was I can't remember, but there was an organization that brought like adaptive sports that are like Olympic sports that are, Paralympic sports. And it was like, try out the, wheelchair track, and try out the sitting shot put, and, all these different things that they would have an expo. And then I think, you meet people, you talk to people and that kind of stuff. Yeah. Does anyone have any other questions, or whether it's specific, I don't know, to parent, to Adrian or Bella?
I guess I have a mini question for you, Sarah.
Yeah.
When like Sean was getting his surgeries and everything, and he was like skeptical about it, were you kind of like encouraging surgery? Were you like what was your kind of standpoint there?
So that one, when he was 12, was an interesting time, because he was pretty adamant. He's like, I am not getting surgery. I mean, and at that point we're like, you're 12, like there was really no way to force it. I mean, and it wasn't a health issue. Like, it wasn't a point where there was a spur that was like breaking through the skin and going to cause an infection. It really was about function.
And that's
So
just like
it-
that's him, all him. Yeah.
yeah, and so it really was like, I mean, we were very straight with him and said, and with the prosthetist, and said like, listen, they have tried this, this, and this, like, and you're frustrated because it's not comfortable, but there's nothing else that can be done prosthetic wise. So this is where you're at, and the doctor does think this surgery will help. It was actually very interesting because at the time, I don't know what he'd say. He did just get home. I don't know what he would say now, but at the time, so his leg had looked like that for a long time. I mean, that was at its end, was like very dramatic of how long that bone was, but it had always been a little pointy. And so the doctor was like, well, we're going to take it. We're going to do a myodesis and pull the calf around, and this, and Sean was like a little bit weirded out by that. And he was like, my leg's going to be different. So it was interesting that it was like, this was his leg. And he was like, you're not like, I don't want it to look different because this is what my leg looks like. So it was an interesting thing, but then eventually it was just, honestly, he just got like, he couldn't keep up with his friends anymore. He couldn't, he was just on crutches a lot more. And he just was like, all right, he was in middle school at the time, not the time that you don't want to be able to go do things. And he would go on crutches and go do things, but it's just that much more energy that you're expending and everything that way. So that's what it was. But it was an interesting time because it was almost like, I really can't like force you to do this. I don't, like,
Yeah.
But yeah,
I totally get that though. The whole like, oh, I don't want it to look different and like just change.
yeah. And I think he was, and I think it was also like, what do you mean you're gonna like hold this muscle?
The concept itself.
I mean, well, you want them to know what's going on. I think at the time it was also like he just couldn't
Kind of picky.
that. So all of that was like.
And has he had any surgery since?
He had last year, he had not any revisions. He has a little bit of a bone spur that was questionable whether it was going to need surgery, but he had to have, his kneecap was dislocating because he has alta patella. So it was like a little bit hot riding high, which the groove that it normally sits in isn't as fully developed, which is probably all just part of the whole deal. But so his kneecap dislocated several times, and so they finally decided surgery was the way to go for that. And so that was the surgery he had to have about a year ago. And it was all a little bit different because of how you have to have it in a brace in the beginning, and he couldn't wear the brace, like he couldn't wear his leg where most kids can start to walk. He couldn't because he couldn't get back in his prosthesis. So it was interesting. It created a few issues with recovery, but it's all good now. His physical therapist, see, this was a case where his physical therapist's office is actually in the prosthetist office. They rent space from the prosthetist office. And that was a really good thing because there was one time where we were all standing there trying to figure out what the best thing for him to do was to help him to get bend his knee. And we had talk about the team approach. It was right there and they came up with an idea and it worked. So it was good. Sean just came home. I'll at least get him to come over to him. But any other questions or anything?
Adrian, you have nice designs on your legs. That's always an exciting part of prosthetic choices, is the designs.
Yes, I had very, very colorful prosthetics growing up. And when you're young, you go through prosthetics very fast. You have a lot of opportunity for different designs.
One of our prosthetists who comes to camp, who's also a below the knee amputee, she, Brooke, she loves to really bedazzle her legs, which I think is cool. So it's always an option.
Yes, it definitely is. But yeah, so this is Sean, who I've talked about. If anyone has questions, so he had surgery last year, he has other surgeries. Do you remember much about when you were in 6th grade and you did not want to have surgery?
Mm-hmm.
Your decision making then? Do you remember?
Well, it
What?
was surgery and I didn't like it.
I know,
Yeah,
well, I
I
get
mean-
that. But do you remember what finally pushed you to?
And not being able to wear my leg for so long and having it hurt.
All right, I want to make sure I was.
Yeah, it honestly, it looked
up with the
like
right
it could be
thing.
painful. It looked pointy and like it would get really irritated. Yeah.
Yeah, so that's it.
What was the recovery like, Sean? Was it hard getting back into your leg again?
Actually, right. So the recovery, it was rough at first, but getting into my leg was pretty easy. Like once it was definitely a lot better.
Mhm.
Yeah,
And I was able to do like a seal-in liner, which was way too uncomfortable before.
yeah. So there were definitely benefits, and the first 5 days were horrendous. Probably
Oh
7
no, we're
horrendous. Yeah, he says they were bad because he doesn't remember them much.
I
They were
do remember them.
horrendous.
They were
But yeah, so that's right. I forgot that he was able to do a different kind of liner because before he couldn't take the tension of any like pulling. It was almost like everything had scarred down there. And so any kind of like extra suction there really hurt. All right, let's see from the chat. How do you feel like you've overcome perceived barriers to engaging in activities? For instance, some parents tend to be overprotective or some kids feel self-conscious.
I can help answer this.
All right, go Adrian.
So I think I personally was pretty lucky. I never really had my parents be very overprotective. They were really like encouraging me to get involved with physical activity at a young age. And one major way that they did that was like even doing physical activity at home, like rollerblading, biking. It doesn't always have to be like organized sports, but like getting me at home acclimated to different like sports equipment before it even like shows up in like gym class or things like that. That helped me a lot. My biggest barrier was definitely feeling self-conscious. It kind of grew more as I got a little bit older in like middle school and high school. And I dreaded things like physical, like PE class at school. And overcoming that, a big part of it was just like being connected with Camp No Limits and having mentorship, and building self-confidence by like connecting with my peers and getting advice and seeing other people kind of overcome these same barriers. So like that ultimately helped me. But another thing was finding like alternative, whether that's like adaptive sports or like other types of like recreation that maybe were less stressful for me, because I definitely got very like worried and self-conscious. So I would like ease into it in other environments, and then it helped me kind of grow out of some of that.
Thank you. You have anything to add there?
No, I never really was like self-conscious or anything. I just was able. I adapted to whatever we were doing. It was like physical activity. I just did my best.
I know you wrestle. What were your other sports?
I played soccer in 2nd grade. That was
Oh, so it was mostly wrestling. Okay.
Yeah, it was. Yeah, he
Did you
tried.
ever like, what if like your leg like never came off or anything? Or do you take it off?
I take it off in wrestling.
Yeah, so
Oh, okay.
So I never
And
really
you
ever
feel
thought-
comfortable taking it off in front of everyone?
Yeah.
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 Yeah, I mean, I think kind of going off of what Adrian said, like going to camp all these years has given me that kind of confidence and like to be able to become vulnerable like that and, show people even if it's scary. I guess it kind of has gone easier with that, but I never really did a lot of sports. I did swimming kind of, but not competitively or anything.
Yeah. And I do think it's hard because Sean was at camp from the time he was 6, but he did always have that personality. Like when he was little, he did not care in the middle of the grocery store. He's like, I'm taking my leg off.
oh, we're doing it now. Okay. Like, it was like, and that didn't really change. But I always think, you can never tell because he has had people in his life that, so many, like you guys. But it's like, I do feel like that has helped through different things of knowing that other people have had gone through surgery, knowing that other, just sort of it just being sort of, it just is, it's like, it's part of life and part of how, how it goes, that I think that's always helped. But it's also just a little bit of, I think, personality a little bit, but because, let's see. I'm a volunteer coming from MCPHS. It's a school in Boston, PT school in Boston. Very excited to be a part, hearing your experience. I realize everyone can read the chat and it's not like the polls and other ones. Oh, I don't know. Was there
I have like this one specific, I don't know why in particular, but I remember one year I played the piano at the talent show. And
oh my gosh, I remember that, Bella. That was a moment.
Yeah, and that was like a moment for me. Yeah. So I kind of like after, I mean, everyone like went crazy about it and it was really sweet having all that support and everything. But to me, it was like, I've never done something like that before. And I remember even like parents would be like, wow, Bella, like I never thought you would do that. And I was like, no, literally me either. Cause I used to definitely have that personality of like kind of quiet and like very attached to my dad's hip, like you talk and, lead and whatnot. So kind of doing that was, I guess, a cool moment for me that, yeah, kind of shaped it.
Very cool.
I don't know if I have like a single moment. I definitely feel like I've gone to camp for so long that it starts to blur together a little bit. But when I was young and first started to go to camp, there was a few like women, like adult amputees that I definitely looked up to a lot. And one kind of silly moment that stands out to me is one of them, I remember like for whatever reason, like shoe selection as a child was like very traumatic for me. It was one of those things like when you have a prosthetic or you have, medical equipment like that, sometimes putting shoes on or choosing the ones that you want is like kind of difficult. And it was something that would give me meltdowns. And I really, really wanted to be able to wear flip-flops. But they always slid off my feet. And one of the women that I looked up to a lot, she like very easily was like, oh yeah, here's this hack I use to like, she puts like fishing line on the back of the flip-flop and holds it on that way. And it's kind of a silly memory, but what I think about now as like a mentor is that so many people have shared these cool like tips and tricks and advice that like as people with limb differences, we've all like had to figure out a lot on our own and adapt. And what I realize now as a mentor is, even though there's many of us who've kind of figured those things out for ourselves, like the more you can share that with families, things that are maybe seem like silly tips, that the more I can share with like younger children and their parents, so they don't have to figure it out all on their own as well. So yeah, I try to keep that kind of innovative and like teaching spirit.
We lost Sean, didn't we?
Yeah, it's funny. He just got back from wrestling, so he's going to eat dinner.
Totally get it.
He's willing to answer questions if we still have. All right, let's see. Do you feel like camp helped you create a community to find support, or did you have a strong community outside of camp, either before or after?
I can answer that one. I mean, it's a resounding yes. Definitely a community of support. I feel like it's a highlight of our year, every summer to go. And we make a trip from Wisconsin out to Maine. And when our first year, we thought, well, we'll try the Maine camp, but then maybe if something comes closer, we'll try to do that. And we didn't realize that people return year after year. So our girls were like, we can't go to another one now. We know all these people who come back to Maine. And we're like, yeah, you're right. We have to go back to Maine. We can't not go. So we're thrilled that there's potential in Chicago this year, which is much, much closer to us. But yeah, we have so many connections in Maine. And for us and for our girls, it's a place where we can truly relax. Like we, I don't know how else to explain it other than that. Like we feel like we can just relax. We're not, you know, aware. Yeah. Not that we're like, I guess, overly concerned about people looking at us or our girls, but it happens. I mean, they look different, and wherever we go, we get second looks or flat out stares, and it's just part of life for us. But at camp, it's like we just kind of let down our guard because we're all there and everybody's having fun and swimming, and it doesn't matter if you have no legs or a backward foot or whatever. Like it just like you're just there and you fit right in. And we see that more and more in our girls, like recognizing that as they get older and are more aware of their limb differences, that there's such a community and the support that we get from other parents. Preston and I joke that like you get right to it with other parents. There's no like, hey, what do you do for a job, or like these things that are part of normal conversation. It's like you right into the deep stuff because you can, and it just brings you to the next level that much faster. You could be talking to someone about like really deep things and then be like, oh, by the way, what's your name? Like I've had to do that before because we're talking about this person's child's accident and like the really deep conversation. So I just like an immediate kind of bond that I feel like we have support with friends and family where we live, but it's a whole new level when you're surrounded by people who like are truly living it and understand.
Yeah, camp was my only source of this kind of community, and it did last a lifetime. It's been many years now, and it's definitely who I consider my family. But yeah, so it's people who become very, very personally close to me, as well as like it was a camp person who gave me my prosthetist recommendation. It's camp people who are coming to my wedding in a few months. It's taken over my life. So I've definitely chosen to stay for a reason.
Yeah, and one thing about camp, and is that like you let down your guard, and I think it was interesting for us as you see Sean, and he says, "Oh, I've never been self-conscious about it," and all that. The first year that we were there, so Sean was 6 and our daughter was 9, and so a lot of you, or some of you know our daughter Jordan, and she was very, very shy. And we joke that first year that we went, that she got a lot more out of camp than Sean did, but it is that place that like everyone feels kind of safe. It's like, it was a place that she finally, like she walked away from us. She went, and it's just something about everyone is there for the kids. Everyone is there. It's just, something about the community. It really is that is for everyone, for the siblings and everyone. So it's cool.
Great question. There's been great questions.
Yes, there have. Any other questions?
For the volunteers, what camps are you guys are you coming to? Maine, maybe my favorite.
Yeah.
Me and Courtney, go to school together, and we'll both be coming to Maine, and we're very excited.
Awesome. Yeah, we'll see you. I'll see you there.
Yes, we will.
All right. So if there are no more questions, I guess we will call it a night. Thank you all very much for getting on. Thank you to Adrian, Jennifer, and Bella for sharing. And anytime, reach out. My number is on the or my email is on the camp website if there's any questions or anything like that. And recording will be on the Elevate site. And coming up, Mary, what's the date? There is going to be sort of like a life hacks, sort of like the top 5 ways that like people adapt for upper extremity differences. And that's going to be April 19th, Mary?
Yes, the 19th.
So
So
that's
we'll
the-
have a similar panel like thing. We'll have a similar panel like we did today, and they'll talk about their top 5 things that they have learned to adapt, things that they kind of like wouldn't want to live without now. So in everyday life. So I think it'll be pretty cool to hear some of those options.
Yeah. Yeah. So thank you all again and have a good night.